are these newer drugs that much more expensive?
Oh,
I gather the answer is yes.
that would be correct. Yes.
That would be yes.
Yeah. So, you know, you're going from some of the MRSA drugs that are, you know, $10 a day, 100 to thousands of dollars. So they're not just a little bit more, they're a lot more. So you have to be very fiscally responsible in how you decide to use them. So they could be the best spent money if it prevents a hospital admission, or it could be a total waste of money.
Right, but the patient's coming into the hospital anyway because they need wound checks, pulse checks, whatever.
That's not the patient, right?
It's not the right patient.
Okay, so this is, we're going to see the cost saving in this drug is the lack of facility use, basically.
Yes.
Correct.
So
It also guarantees compliance, and I think that that's a big, at least in my patient population that I deal with.
how do you monetize that?
What's that?
How do you monetize
It's very
that?
difficult.
Well, the way you monetize it is you look at readmission
That's
rates at 30 days,
Absolutely.
which as a CMS benchmark actually is something people are very focused on right now. And if you can show, because you didn't put the PICC line in, they didn't get readmitted at 30 days because they either didn't overdose on the best stuff that they cook in Ohio, or they didn't, you know, get a secondary complication from the PICC line, that's cash in someone's pocket at the hospital administrator level.
But do you get to your silo point, though, that comes into play, right? That whole thing has to have all of the different players from the different groups, because no matter how you look at it, that's $3,000 into my budget. And why is the budget up this amount? Even though you've stopped reading, you have to have
it's
that.
It's your budget, it's not the hospital's
it's
budget
mine.
for my patients.
Yeah. Right.
Okay, I just wanted to understand that.
So we should turn this upside down, I guess. If we know the cost of this medication, which is high, what is the cost in dollars and cents of non-compliance? Because the cost of not using this drug is that somebody has to comply. Somebody's got to use it, come back, use the pills, do whatever you need to do. How do we monetize that? Can we do that?
Well, you could say the cost of noncompliance at the most basic level could be an admission.
Okay.
That wouldn't have had to be done otherwise, right?
Okay.
So you can find out from your facility what the average cost of an admission for a skin infection is, but I would say probably $8,000 to $10,000 would be an accepted, you know, cost, with much higher charges certainly out there. So, you know, if the patient stays for, you know, 3 days, they stay for 7 days, an entire course of IV antibiotics, then you can double that number or more. So.
And what about the doc who says, well, you know, this is a community-acquired infection, whatever that may mean these days, which is meaning less and less. I'm going to use a less effective drug, but it's likely to work. What is the cost of that decision across the board, all comers?
Yeah, so that's the cost of failure. So, you know, the most expensive antibiotic is the one that doesn't work.
Okay.
And so, you know, that's where you have to know what is the probability of this antibiotic working for this patient. And so there is a cost for failure, and it's usually prolonged length of stay, and there's a societal cost. You know, if you're working for a living and you're sitting in a hospital and you can't work and you have children at home, and, you know, it starts escalating and snowballing all the other people affected by that failure. So there's a lot of, you know, we don't put a societal price tag on that, but that is the reality of our decisions.
Can I just be precise about language here? Because this phrase, less effective, keeps getting batted around, and I think that's an entire misnomer and a falsehood. There's no evidence that these newer drugs are more effective, right? The other agents, if they're not effective, it's because you didn't pick the right spectrum of activity.
Okay.
Right, but I think saying less
Or the
effective,
right dose.
Or the right dose, right, all of these things. But the drug itself isn't less effective. It's the doctor or the pharmacist or the clinician made a bad choice among the tools in the toolkit.
So they picked the wrong drug.
Right, so I would be careful that, because again, I think it gets back to this conversation we started with, which is how did we get in this mess? We didn't personalize it, the decisions we make, we own.
Okay.
Right? And I think we need to say, less effective implies that it's the drug's failure. If the drug didn't work, part of it's doctor failure.
Okay,
because we picked the wrong dog.
Picked the wrong drug. The other question I have is this whole question of silos. Right. Well, it's my $3,000, right? Who says? Right? How come we can't just get, this is the hospital silo, and it's our problem as an institution that takes the onus off of you, and it allows more across the beach, if you will, the waterfront, decisions to be made. Why can't we do that?
We try, but as a challenge. So when we talk about antibiotics, it's the pharmacy budget that's getting hit for using more expensive antibiotics, and it's the overall hospital budget that benefits from not having extended length of stay. But go back to the rapid diagnostic example, it's the lab that has to purchase this particular test or this particular instrument, and then particularly the pharmacy may benefit from less utilization of antibiotics. And so we actually had a scenario where our health system would not support bringing in a new rapid diagnostic because of cost to the lab that was not budgeted. And so we actually had to collaborate with lab and actually transfer money from one budget to another budget such that we could have this. So I think we're getting there, but it's all about collaboration and all the way to the very top.
You have to talk to one another and actually be nice play nice in the sandbox?
Yes.
Look, I'm not a CPA, and I don't play one on TV. But it occurs to me that if this sandbox belongs to all of us, savings here can offset expenditures here unless you build these artificial walls.
I think that occurs to all of us in this room.
Who's it not occurring to is what I'm asking.
But again, the dilemma for the hospital administrator, again, is part organizational, right? Because they send out budgets and they come into buckets. Right. And there's very little at the leadership level strategic thinking in the classic MBA sense, looking about where the system's going to go in the mission. But at the same time, our hospital leaders, and I appreciate this, nonprofit hospitals, which all of us work at, live on 2% margins. The Stop and Shop that I went to get my coffee at this afternoon has a better margin as a grocery store.
I hope so.
We are always in a mess. We are constantly the focus of efforts by CMS to rein in costs, and it's often the budget is balanced on the back of the hospital. So even if you can break down those silos, there's going to only be escalating cost pressure on institutions. And perhaps that actually means it's an opportune time to actually make these arguments, but you have to have a well thought out argument that shows it from a systems level to the right person in the C-suite.